Bonjour tout le monde, est-ce que vous m'entendez? Un petit peu fort ici. Donc ici, on nous entend. Donc on vous parle aujourd'hui d'un endroit un petit peu différent d'habitude puisqu'on est tous à Bruxelles, où vous savez qu'on va lancer ce soir le second sommet de la médecine de précision en psychiatrie. J'espère que vous vous êtes tous inscrits sur le lien qu'on a dû vous envoyer et vous renvoyer. Sinon, dites-le nous, on vous le renvoie parce que le programme est absolument formidable. Et comme vous savez, commence ce soir à 17 heures et puis va durer toute la journée de demain et de vendredi matin. Mais on n'est pas là pour ça, on est là pour continuer à explorer notre voyage pour vous décrire la médecine de précision en psychiatrie. Et aujourd'hui, on est très très heureux et très chanceux parce qu'on a avec nous un des leaders du domaine que vous avez sûrement déjà entendu si vous êtes venu dans les différents congrès européens ou internationaux où on a la chance de l'entendre. Et j'ai le très grand plaisir d'introduire le professeur Brenda Penninx. Brenda est professeure épidémiologiste. Elle est professeure et présidente du département de psychiatrie de l'Université d'Amsterdam. Elle est aussi l'investigateur principal d'une très très grande cohorte qui dure depuis 2013, si je ne me trompe pas, qui s'appelle la cohorte NESDA, que vous devez connaître aussi tous, est une très grande cohorte de patients déprimés et anxieux et maintenant de leurs enfants. Et elle a aussi, ce qui témoigne de sa très très grande compétence et talent sur le plan de toute une série d'activités scientifiques, elle est la vice-présidente de l'Académie scientifique de, de Hollande. Et comme elle est très modeste, je vais me permettre pour une fois de donner des chiffres qui montrent l'importance de ses publications et de son rôle sur le plan scientifique international, parce que vous savez que les femmes sont souvent modestes et ne donnent pas ces chiffres. Donc, elle m'a autorisé à citer pour que vous vous représentiez un petit peu l'importance de ces publications. Elle a un H-index que nous n'atteindrons jamais puisqu'il est à 193. On vient de vérifier il y a 2 minutes, ce qui est très, très impressionnant. Et il y a une classification maintenant des femmes chercheuses scientifiques dans le monde et elle est la 13e femme chercheuse de tous les domaines scientifiques. Donc voilà, vous avez le droit de l'applaudir, de vous sortir vos caméras là pour que on vérifie que vous avez entendu tout ça et que vous êtes tous comme moi extrêmement heureux d'entendre Brenda. Vous avez le droit de sortir tous les petits bidules pour dire bravo, là, les goodies et autres. Bon, après cette introduction, donc on donne la parole à Brenda Penninx qui va vous parler donc un de ses domaines qui est la découverte et la description d'un domaine, d'une entité clinique extrêmement importante pour la médecine de précision en psychiatrie, qui est la dépression immunométabolique. Et elle va vous expliquer comment ça a été conçu et comment c'est en train d'être implémenté dans la pratique clinique. Brenda, thank you so much and the floor is yours.
Thank you so much, Marion. It's really nice to be speaking to lots of you online and a few people here in the audience. And I'm really happy to take you along on a story that really looks into the conceptualization and the etiology of depression, because that's really what I have been focusing on during the last 30 years of my scientific career. And I call my talk Immunometabolic Depression because that is what I will be zooming in on during my talk today. But first, I think it is important to keep realizing why research in psychiatry is so important. And these are some really strong arguments for why I focus on depression in my research. We do know that depression is really a really prevalent condition. 6% of the population suffers from depression in a given year, and about 15% during their lifetime. The WHO looks at and compares all kinds of different conditions and the impact conditions have on disability during life. And they conclude that depression is really one of the strongest contributors to disease burden, as compared to lots of other conditions. I think it's sad to say that the impact that depression has on disease burden is actually stable for the last 30 years. And that is really illustrated in the blue line that you see in the figure below. That's the impact, comparing the impact on disease burden for cardiovascular conditions with depression. And as you can see, for cardiovascular disease, there has been a decrease in the impact that these conditions have on disease burden in the last 30 years. But for depression, this has not been the case. And I think it's important to realize that, because that means that despite the fact that there are probably lots of ways how we can treat and prevent depression, we're not able to really change the curve of the impact of depression on our society. Despite the fact that there is potentially more consideration for mental health, I think these days as compared to 30 years ago, and there are also more treatment opportunities. Despite that, I think we still have a job to do. And I think we have to wonder as a field why the impact of depression is so large. And if I think about that, I think there are a few key discriminating features that are inherent to lots of mental conditions, but especially also due to, also in depression, that are contributing to this large burden. The first is obviously that it is a rather common condition. So there's a high prevalence, and that is necessary to, at the population level, to have a large impact. In addition to that, I think there is more and more evidence that depression, although lots of people say, well, that's an episodic condition, you treat an episode and then the disease is gone. I think there is more and more awareness of the fact that chronicity of depression is huge. Also in our project, we are following lots of depressed patients for quite a long time period, and we really see that chronicity is the rule, not the exception. Also, another feature that is, I think, rather specific to mental health conditions is that it really starts generally very early in life. So the average age of onset for people with depression is in their early adulthood, around the age of 25 to 28 years on average. So that really means that lots of people suffer from these conditions for a very chronic time period, especially when you compare it to lots of other somatic conditions like cardiovascular conditions that also have large of impact on disease burden, but they arrive at a much later stage generally in life. And the fact that diseases can be chronic and they already start early in life, it also means that they can impact a person for really pronounced stages of their life. We know the impact on functioning is huge, not just on social functioning, on personal functioning, but also in terms, for instance, of work functioning. And that really means that for the society, depression has a huge impact. And it has been estimated that half of all work absence is due to mental conditions, with depression playing a major role there. And then there is the indication that mental health and somatic health are very much interacting with each other. So the impact of depression is not just due to depression, but it is also due to the fact that depression can impact on other disease etiology, but also disease course trajectories over time. I think underlying problems in why the impact of depression on society is so large are two other key concepts that we have to consider when we are thinking about depression as a concept. First, I think despite the fact that we do have medications and treatments for depression, I think we also have to be aware that treatments are still suboptimal. We know that antidepressants are effective, but not for all. We also know that despite the presence of treatment options, there is still a mental health treatment gap, also in Western societies. And I think a second issue is really the heterogeneity of the concept. I just showed you before already the symptoms of depression. And if you just look at these listed here in the box, you can immediately see that there is quite some diversity of the types of symptoms that people have. And in fact, you can have a depressed patient that fulfills the depression diagnosis, but actually has no symptoms overlapping with another person that also fulfills the depression diagnosis. Some symptoms even go up and down. You can have a depressed person with hypersomnia, really with lots of sleeping behavior, sleeping and napping all the time. And you can have people with insomnia where they actually can't fall asleep. So that's already a discriminating feature that you can really think of as a dimension that is very diverse across a patient population. And I think this is important to realize, because I think by having a heterogeneous concept in terms of symptomatology, but likely also in terms of etiology, it's not very easy to come up with a one-size-fits-all approach in treatment and in clinical care. And I think that's really what we need to be aware of, so that we can better understand how to better understand and make the concept of depression more homogeneous. And that's what my talk will be focusing on. So let's take one step back and ask the question, what do we know about the etiology of depression? This is a map of psychiatric genetics picture where you see the heritability on the y-axis, and you see the conditions and the prevalence of mental health conditions on the x-axis. And as you can see, depression is a very prevalent condition, but it's actually having low heritability as compared to lots of other psychiatric conditions. So there is a genetic component, but it is not as strong as, for instance, in schizophrenia or in autism disease. What do we know about the genetic basis of depression? Despite the fact that it's not so heritable, we actually start to learn more and more about the genetic basis of depression. And this is a picture from a paper that has been just submitted to Medical Archive, where there is now an analysis of the genome-wide basis of depression in over 600,000 depressed people and more than 4 million controls. And they now have identified almost 700 independent genetic variants linked to depression. This paper, which is on Medical Archive, also links genetic pathways and clearly confirms that the genetic pathways that are over-enriched in people with depression are very important pathways for regulating the brain. So I think also the genetics data tells us that depression really is linked to brain function. However, what we can also learn from the genetic basis and these genetic studies in the field of depression is that also inflammatory and metabolic processes are key. Also, when you look at the genetic basis and the gene pathways, for instance, that are over-enriched in depression, immune and metabolic processes are highly relevant, also from a genetics point of view. What about neurobiological dysregulations? Well, this is a slightly old picture, but I think there is evidence, and that confirms the genetic basis connection that I just showed you, where genetic pathways are heavily pointing towards brain process involvement. But there is evidence both at the structural, the connectivity, and at the functional activation level that people with depression have smaller hippocampus, smaller amygdala, and a different activation to negative and positive stimuli in the emotion regulating processes, including, for instance, the hippocampus and the amygdala, the prefrontal cortex. But it's not that depression is just a brain condition. And I think this picture clearly shows that. This is a picture connecting depression through stress systems to entire bodily functions. And if you think of depression as a chronic stress activating disorder for a person, then immediately it connects to dysfunctions of stress systems in your body. And I think we have 3 key stress systems in our body. One is actually the HPA axis that most people will really think of when you talk about the stress axis. So the HPA axis is the axis that after stress exposure takes about 15 minutes to release the stress hormone cortisol and shows an increase in stress hormone cortisol release, and that goes through the bloodstream and arrives at all kinds of organs. So that immediately already shows that stress and stress conditions is not just limited to the brain, but really arrives and has impact on the entire body. The other stress system that people think of a little bit less often is the autonomic nervous system, which is actually the most immediate stress system. If you're exposed to stress, it's immediately that you experience a heart rate increase, your blood pressure goes up, your eyes wide open. And those are more immediate responses that are completely due to the innervation of the parasympathetic and sympathetic nervous system. And then there is a third stress system, which some people don't even call a stress system, but I think it is, and that's the immune system. And that is the slowest to response system, but due to some physical agents and, for instance, viruses or other arousing particles, this is a system that activates by, for instance, releasing cytokines and monocyte activations. These stress systems are interacting with each other, but they're not only involved in mental health, they're also quite well known to be very relevant for the development, for instance, of cardiovascular conditions. So these are key bodily stress systems that immediately connect the brain with the rest of the body and also link brain conditions to other conditions in the somatic fields. In addition to that, I think we also are more and more aware of the fact that depression is involved with disrupted energy-relating signaling. We know that depressed people are more likely to present with insulin and leptin resistance, for instance, and there are now more than 10 meta-analyses out there showing a bidirectional longitudinal link between, for instance, depression and obesity. One illustration of the involvement of metabolism in depression is arriving from a metabolomics meta-analysis that we conducted a few years ago, where we actually took data from 8 different cohorts, so more than 5,000 depressed cases and 9,000 controls. And we actually looked at a very general metabolomics platform that has massively assessed lipids and lipid dysregulation. And by just meta-analyzing these data, it was clear that out of the 51 examined metabolites, 21 were significantly linked to the presence of depression. And that really clearly showed a shift towards less high density lipoprotein and more very low density lipoprotein, so the unhealthy lipids, and higher levels of triglycerides in people with depression. So I think this whole stress system dysregulation can also be really seen very clearly at the metabolism sides and involves lipid metabolism as well. But then if you really look at the meta-analytic evidence, so I just showed you some general mechanisms, and this has really been confirmed in many studies out there. And has actually, for all of these indications I highlighted, there have been meta-analytic evidence now linking, for instance, high cortisol, high C-reactive protein, high interleukin-6 inflammatory marker, but also insulin resistance and leptin resistance and the metabolic syndrome and obesity to depression. However, if you then look at meta-analytic data, it's also very clear that there is quite a large heterogeneity across studies. And then I think that's something to be aware of. In addition, I think it's also good to realize that when we talk about these biological mechanisms and the association with depression, we never arrive at huge effect sizes. Effect sizes are significant, they're there, but they're very often below 0.2 or 0.3. So that really suggests that these associations are at least modest and sometimes really lower than that. I think that's important to realize because I think that does tell us something. Well, obviously the heterogeneity of findings across studies can be due to the fact that studies have used different methodologies, have used different samples. But I think it's also probably due to the nature of depression. It's such an heterogeneous condition that this is adding to heterogeneous findings in the literature for research as well. And I think we really have to learn and better realize that if we talk about all these kind of general mechanisms underlying the pathophysiology of depression, it doesn't mean that all the depressed people suffer from all these pathophysiological dysregulations. There may be really heterogeneity there too. And I think that's really the essence of personalized medicine, or probably I should have written here, precision psychiatry. So we really should look more closely at what are then the people who have these dysregulations. What is discriminating them from people that are not suffering from certain pathophysiological dysregulations? We have this heterogeneous group of people with disorders, and we really need to arrive at clinical biotypes that are much more uniform, as this clear picture by Leanne Williams clearly indicates. And it's very unlikely that we can just arrive at a new stratification without incorporating an etiological data. For instance, biological data on biomarkers, but also potentially cognitive or MRI or even genetic type data to really arrive at more homogeneous clinical biotypes. I think it's also important to not forget about the environment and the life experience, which is also listed here in this classification, that we can really, I think, also start to examine to what extent we can use etiological risk factors that people indicate. For instance, the presence of childhood trauma or so in the past, which we know is increasing dysfunction of certain stress systems. Also to better identify people with a certain underlying pathophysiology. But if we have better information on what are more homogeneous clinical biotypes, then we can really arrive at the point of personalized treatment options. And we are clearly not there yet, but I think this is really where we should go to in the future. So I am going to show you some data now from the Netherlands study of depression and anxiety. I know I couldn't really follow the complete introduction in French by Marion, but I did figure out that she mentioned this. And I also think she mentioned that this was started in 2003, which is indeed what it is. So for the last 20 years, we have been running the Netherlands study of depression and anxiety, which is a big cohort study, patient-based cohort study. It also includes healthy controls. And we are still following these people over time. This is now for some of the people 15 years ago that we had the first baseline meeting, and we're actually currently working on a 19-year follow-up assessment in the original sample. This sample has over-recruited people with depression and or anxiety disorders, but as I mentioned, also included some healthy controls. It's a collaboration across the Netherlands with multiple university medical centers involved, and we have done several longitudinal data collection waves over time. It also has yielded more than 100 junior PhD students that used at least for two of their chapters of their thesis, used NESDA data to graduate. So I think this is really a very nice way and a great research infrastructure for junior scientists to use and learn how to make the first steps into research. So one analysis we did in the NESDA project is take everybody who had a current major depressive disorder. So we had 818 people with a current major depressive disorder at baseline. And we basically asked the question, if we now just take the individual item scores on their symptoms, if we just look at symptom patterns, what are then more homogeneous clusters of symptoms? Because it is clear that if people have certain types of symptoms, they are more likely to also have some other types of symptoms as compared to people who, for instance, do not have that starting symptom. So also symptoms cluster in a certain way in a depressed population. And as you can see, It's not very visible from this slide, but I have translated it in another slide. There are three subgroupings we could make based on this data-driven latent class analysis. And this is probably an easier way to show that, but because we arrived at three classes. The first class just being a slightly more moderate depressive severity class. So they had the lowest scores on most of the depressive symptoms as compared to the other two classes. But then we have two other classes that we called severe typical and severe atypical. And these people did not differ in terms of overall disease severity. They had as high inventory of depressive symptomatology score, which we use to measure depression severity. However, they differed in the types of symptoms they had. The severe typical depressed people, they were showing the poorest ratings on depressed mood, on weight loss. They had more decreased appetite, they had less sleep, they were highest suicidal, and they had poorest rating on quality of mood and early morning awakening. And this really is more and more in line with what the DSM calls the more typical depressive disorder, or the melancholia. Although the melancholia, according to the DSM criteria, also scores psychomotor retardation and diurnal variation, and we did not find any evidence in our data-driven approach, which is really in contrast with the DSM approach, which is consensus-based. We did not find any evidence that psychomotor symptoms and diurnal variation really cluster together with the other symptoms of the melancholia. Then we also had a severe atypical group of people. That was about a quarter of all our depressed patients. And they were the ones who had most weight gain. They had increased appetite. They had more sleep, so they had hypersomnia. And they had highest reportings of fatigue and energy loss and lead-in paralysis. And that really is more and more in line with what the DSM calls atypical depression. However, again, the DSM also says interpersonal rejection sensitivity and mood reactivity is relevant for atypical depression. And that is not confirmed in our data-driven approach, because these two symptoms did not cluster within the severe atypical subgroup. So you can use data-driven approaches to also look at more homogeneous groups of patients just based on symptoms. And that really mimics a little bit the DSM classification of melancholic versus atypical depression, but not exactly. But then we started to ask the question, well, if we have these two subgroups, they are not different in terms of severity, they are as disabled, they have as often comorbid anxiety. How do they differ? What else is different except for their symptomatology? Well, we looked at correlates, and for instance, here see that smokers are more often the more typical depressed patients, and they are also the ones who had most reports of negative life events and childhood trauma, and they were the ones with most persistent anxiety and suicidality over time. The atypical depressed people, the ones who had symptoms of increased appetite and weight and low energy, hypersomnia, lead-in paralysis, so more atypical energy-related symptoms, they were the ones who were slightly more often female, had an earlier onset, and showed the persistent poor metabolic profile, as I will show you later. And then we went further and asked the question, well, these are correlates and cores, but what about pathophysiology? So then we, for instance, because also in NESDA, we have measured immune metabolic dysregulations, and we started to look at that again in our subgroups now of atypical and typical depression. And what you see on the first part of the graph here, the blue dots, is just a comparison between depressed cases and controls for CRP, IL-6, TNF-alpha, so the inflammatory markers, but also for BMI, waist circumference, glucose, triglycerides, and HDL cholesterol. And then if you dare look, well, you do see some subtle differences. You see, for instance, that the BMI is higher in people with depression, waist circumference is higher as compared to controls, but not so much for the overall other indicators. However, if we do the same comparison to the same controls, but now only for people with atypical depression, so this subgroup of 25% of the overall depressed group that scored different on and higher on the atypical energy-related symptoms, then you actually see much stronger and much more significant associations with immunometabolic dysregulations, where you do see that people with atypical depression have higher levels of inflammatory markers, higher BMI, higher waist circumference, higher levels of glucose and triglycerides, and lower HDL cholesterol, so the healthy lipid level. We also did some other differential analysis to see whether the differentiation between atypical and typical depression is also prominent if we look at some other proteins. So this is a picture that is coming from a proteomic profile that we did in all our NESDA participants, measuring 171 serum proteins. And here the simple question is, do these serum proteins contribute to differentiating between atypical and typical depressed people? And yes, they do. Here you also see, for instance, at the bottom, that insulin, CRP, and leptin, again, with a different measurement approach, are highly discriminating people with atypical depression from typical depression. And the ones with atypical depression had highest evidence of insulin, CRP, and leptin levels being increased. A similar analysis we did with a more extensive lipidomics profile using the Nightingale Health platform, where we measured 51 lipid measures, looking at lipids, fatty acids, and low molecular weight metabolites. And we did that in the entire NESDA population, but this is just showing the discrimination again between atypical symptomatology versus general symptomatology. And the red dots here are again showing, the red dots are the dots that are linking atypical energy-related symptoms to these markers. And as you can see, the association between the atypical energy-related symptoms with these metabolites is much stronger than it is for the general depression severity. So this really illustrates that there are subgroups of depressed patients where immune and lipids dysregulations are just much more extensive than in other people, in other depressed people. This is a slide just to highlight that it's not only us that are finding the relevance of different depression symptom subtypes and the relevance for associations with immunometabolic dysregulations. There are now, I think, more and more studies confirming the findings that I just reported from the NESDA project. So that really leads us to really think that the pathophysiology underlying atypical and typical depression are really different. And I didn't show you that here, but we also have evidence that hyperactivity of the HPA axis by measuring a few times during the day saliva cortisol levels, which we did in the NESDA project, shows more involvement of hyperactivity of the HPA axis, especially in typical depression, but it are really immune inflammatory metabolic dysregulations, leptin and insulin resistance that we see much more prominent involved in atypical depression. And that's why we are starting to call this group now not atypical depression, because I think it's a confusing term, but we call it immunometabolic depression, because that, I think, is in essence what is underlying the dysregulations that we see in these patients. So these people differ in the types of symptoms they have. They differ in some of the correlates, they differ in the course, and they differ in the pathophysiology. Well, then the last question was, can we also show that back in a differential genetic basis? And I think obviously when looking at the genetic pathways, we're getting more into the causality of some of these underlying factors, because some people can still ask the question, well, what is the chicken and the egg here? Is immunometabolic dysregulation not just a consequence of depression, or is it truly something that is, in essence, also contributing to the etiology? And I think genetics can give us more of an answer to that. Well, first, what we did in our project is we have measured gene expression at baseline in all our participants. And you can use gene expression data. So we measured the expression of almost 20,000 genes. But you can examine in those 20,000 genes, what are the gene expressions related to depression? And can it be that inflammatory gene pathways are more involved in the association with depression than other types of pathways? That's the question we asked. And as you can see from these circle plots, we actually found quite many inflammatory genetic pathways to be enriched in people with atypical depression. So that's the pink circle. And there was hardly any over-enrichment of inflammatory genetic pathways at the gene expression level in people with typical depression, the green circle. So again, gene expression is telling us that the gene expression inflammatory pathways are differentially involved in atypical depression, but not so much in typical depression. Then we also looked at the DNA level, because in our project, we do have genome-wide data also. So we contributed to the Psychiatric Genetic Consortium on GWAS analysis with depression. But GWAS analysis also gives you a perfect tool to better test the genetic basis of conditions. And one really nice tool from genetic studies is that you can calculate polygenomic risk scores, which are the sum of the genome-wide risk alleles. So you just run a GWAS analysis and basically sum up the importance of the relevant high-risk alleles. And that arrives at a sum score that tells you basically whether a person has a low versus a high genetic vulnerability for that trait. The good thing is that you can do that for all kinds of traits, because you can take summary statistics from GWAS studies that are published in the field for all kinds of conditions, and then generate the polygenic risk score. And for instance, look at how is the genetic vulnerability of obesity? How is the genetic vulnerability of schizophrenia in certain groups of people? And that's exactly what we did. So we generated, for instance, the polygenic vulnerability score for schizophrenia, body mass index, CRP, and leptin, and BMI adjusted leptin. And these are some findings shown here. So to just only highlight a few examples, what we did find in NESDA, again, comparing typical and atypical depressed people and look at their polygenic signature, is we do see that people with atypical depression have a higher genetic vulnerability for BMI. And people with typical depression actually have almost a significantly lower genetic vulnerability of BMI, of high BMI. For schizophrenia polygenomic risk score, we did find increased genetic vulnerabilities in both groups, but the risk was really higher in the people with more typical depression. So this is just an illustration of using polygenic signatures to really better understand the genetic vulnerability of subgroups that we can study in our cohort. We also extended these analyses to the UK Biobank and to the Psychiatric Genomics Consortium, basically confirming our finding that people with atypical symptoms, atypical depression ratings, were the ones with the highest genetic vulnerability on BMI, CRP, leptin, and actually in the UK Biobank in several other immunometabolic traits. I think I should skip here. And just show you now the more general picture which we arrive, where we can really put this all together in one box now and add the genetic basis as a key characteristic that is discriminating between typical and immunometabolic depression as well. So from these findings, what do we take? We do think there is a subtype of depression, which is prevalent in about a quarter of all the depressed patients, where immunometabolic dysregulation is just more prominently present. And that is also visible in a slightly atypical symptom profile with more ratings of hyperphagia, weight gain, fatigue, lead-in paralysis, and hypersomnia. And we also think that this really links very well to this group being a risk group to be connected to metabolic conditions like obesity, diabetes, and cardiometabolic conditions, for instance. Well, my last slides, I want to talk a little bit more about what does this mean? What does this mean for clinical care? Because I think it's nice to be looking at these subtypes, but if there is no meaning for clinical care, then yeah, this is just an academic, a nice exercise. But I do think it holds relevance for clinical care, and I will show you why. Well, first, I think it's important to realize that there are some indications that immunometabolic dysregulation, so the presence of inflammation, the presence of certain metabolic dysregulations like metabolic syndrome, for instance, has shown to limit the response to standard antidepressant treatment. We actually examined exactly that question by using 4 big trials out there in the literature, and they are, I think, almost the biggest antidepressant trials that we have out in the field. The iSpot-D study, the COMET study, the GenLab study, and the EMBARK study. So we actually collaborated with people who run these studies and asked the question, if you would measure at baseline immunometabolic depression features, such as the presence of these atypical energy-related symptoms, high BMI, high CRP, and also their combination, would that really truly predict a poorer response to antidepressants? Well, the answer is a little bit. We did find significant evidence that the combination, especially the combination of these features, are identifying people that do more poorly respond to antidepressants. But it's not such a strong effect that I would immediately say, well, we should use it as a selection criteria, and we should not even give antidepressants to people with immunometabolic dysregulations, because the difference was not so large, but some evidence indeed to indicate that immunometabolic dysfunction may be even in the way of adequate depression treatment. Then another reason why I think we need to be interested from a clinical field is that there is also evidence that anti-inflammatory treatment can really be beneficial for treating depressive symptomatology. And this slide shows 2 meta-analyses where they really looked at the literature of various anti-inflammatory treatment options and asked the question from randomized trials, if people are receiving anti-inflammatory treatment as compared to placebo, are the ones on anti-inflammatory treatment doing better in terms of their improvement of depression? And both meta-analyses showed for several of the anti-inflammatory treatments that they looked at, that that was indeed the case, and also was in a meta-analysis confirmed at the overall sum level. It's good to be aware of the fact that these studies are not per se psychiatric patient samples. So they are sometimes based on rheumatoid arthritis patients where they provide anti-inflammatory treatment and where they had depressive symptomatology measures available at baseline and after treatment. And they could use the data to look at change in depression. But obviously, we cannot take this evidence and say we should implement it, because I don't think it has been tested enough yet in our psychiatric patient population. 2 studies that did test this in depressed patient populations in our psychiatric clinics are these 2 studies. One study by Razon et al., where they treated randomized subgroups of depressed patients with infliximab, monoclonal antibody targeting TNF-alpha, and another study where they used minocycline and had a 4-week RCT, so also placebo-controlled, where they randomized people, depressed people, to either minocycline or placebo. If you look at these two studies, and if you compare the treated and the placebo group, you would actually not find a difference in depression improvement. Well, then you can say they are negative studies, which in fact they were. However, what they never did in these studies is they selected people. They randomly took depressed people. And I showed you before that I don't think it's reasonable to expect that everybody has immune dysregulation. I showed you the NESDA data. I showed you that I expect that about 25% of all depressed people fulfills this atypical feature with immune metabolic dysregulation. So if we start treating the entire depressed population, yeah, we can probably not expect to find significance. When they went back to their patients and measured CRP levels at baseline, and then looked at stratified analysis and only, for instance, looked at people with low versus high CRP, they did start to see a differentiation in effects for people with high CRP. And it was in the high CRP group where they showed that anti-inflammatory medication was more favorable than placebo. The problem with these trials is I think they're really great proof of concept trials, but they were not having enough sample size to really allow for adequate stratification. And they really lack power to, I think, convincingly show that this really holds in a larger clinical sample. That's exactly where we need to work at. And that's, for instance, one of the things that we're doing in the inflamed randomized clinical trial that we're running currently in Amsterdam. And in this study, we actually only target people with atypical immunometabolic depression. We select people on the basis of atypical energy-related symptoms. We select people on CRP, and we also obviously measure lots of other things. But here, we actually recruit, and recruitment is obviously more difficult because now we have lots of depressed people, they want to participate, but they don't fulfill because they do not have the atypical energy-related symptoms or they do not have high CRP. So recruitment process for these kind of studies is more difficult, but I think we're really hopefully targeting the more appropriate group of people where we truly can expect a difference. And in this study, we are using celecoxib versus placebo. And this is going on, so I can't tell you the findings yet. But this is not the only study that is going on. And I think it's really nice to mention that at the moment, for instance, in the Antwerp lab by Livia de Picker, they are running a very similar study. We actually have aligned several of the measurements that we're doing. And also in other countries, there are some studies going on in this field. And we are really planning to collaborate with each other to really put our data together to more convincingly analyze who are the ones who are potentially benefiting from anti-inflammatory medication. So I think the idea behind this is really precision psychiatry. We know that not everybody has immunometabolic depression. We only need to target those with specific interventions that might work best for reducing immunometabolic underlying dysregulations. But how to identify these patients? What are the specific inflammatory markers? What are the specific clinical features? Clinical characteristics, can we even better identify this subgroup? I think is still something that is needy of more research. And that's exactly the goal and the topic of a recent welcome grant that we got. And this is led by Carmine Pariante from London, from KCL. And in this project, we are really bringing together all kinds of groups with data on anti-inflammatory interventions. We're planning on analyzing our data together to really see whether we, across studies, can find the best target population within the depressed patient group. So this is work for the next 3 years. Then finally, I want to end with some other slides because I think we are in the field of psychiatry really ignoring lifestyle. And I think there is ample evidence that lifestyle is very important for immune metabolic function. We know of lots of studies in the field of exercise interventions, and this is not in the field of psychiatry, but outside of psychiatry. But there are lots of exercise studies where they have tested the impact on inflammation and, for instance, the impact on metabolic dysfunction. And they show quite overwhelmingly that people that are more active and that are participating in exercise interventions could really reduce their immune metabolic dysfunction. So this is just an example from the field of CRP, but there are also studies indicating this for fat or lipid metabolism outcomes. And on the other side, we know that exercise can also help decrease depression. There was actually a quite recent BMJ paper that analyzed and compared exercise intervention studies and even compared it to cognitive behavioral therapy and antidepressant medication, and at least suggest, and I have to say the evidence base for exercise interventions is obviously really much smaller than it is for antidepressants and for CBT, but it does show that overall there is no reason to expect that effect sizes for exercise intervention is much smaller. So I really think this could be a beneficial intervention that we should give and could give to our patients, and maybe really especially relevant for people with immunometabolic dysregulations, because we know that exercise is doing well for the entire body, including those cardiometabolic and immune metabolic outcomes. In a study where we have directly included running therapy in our clinic and compared the effects of 16-week running therapy with 16-week antidepressant treatment, which is called the MOTA project, we actually were illustrating that the reduction that we saw in depressive symptomatology and anxiety symptomatology in the patient population that we recruited was indeed very similar for the two intervention arms. So this was a quite severely depressed patient group to start with an average IDS score at baseline around 45, so quite severely depressed. We did see some improvement, although not everybody improved, but there was no difference in improvement patterns for the two groups. However, if we then look at immunometabolic health outcomes, so they were measured at baseline and after 6 weeks as well, and here you can see the change scores in these immunometabolic outcomes. It was actually, despite the fact that this was really not a very large study, so we had 96 people in the running therapy group and 45 in the antidepressant group, but there were actually already quite some significant differences between those two interventions. So despite the fact that the overall depressive severity did not change, we did see deterioration in immunometabolic health in the antidepressant group, with people showing increase in weight, increasing in waist circumference, increase significant of triglyceride levels, and an increase of C-reactive protein. However, if you look at the change in the running therapy group, we do see a decrease in several of these measures. So they had decreasing weight, they had decreasing weight circumference, and they did not show the same increase in lipids and immune metabolic measures. And for some of these measures, this was already significant, especially when we even looked at the people that really adhered well to the protocol. And that's obviously a problem with running therapy. You have more people that are non-compliant than when you give pills. But overall, we did have people that were really very active and really during the 16 weeks adhered to the running therapy protocol. And that was actually the group where we showed most differences and even showed a decrease, for instance, in CRP levels. That was now significant between the running therapy and the antidepressant group. So, and I think this really shows that mechanistically, running therapy may actually do well for some of these immunometabolic health outcomes. So with that, I know this was quite a large overview, but I think I hopefully have convinced you that depression is a really heterogeneous condition and that we really need to better understand what is underlying a specific individual patient. I showed you that immunometabolic stress is more prevalent in depression overall, but I also showed you that it is not present in all depressed people and that we really need to better understand whom are most at risk and how they can be identified so that we can really direct our interventions to those that need them specifically. And especially when we start targeting immunometabolic stress, we really can think about other types of interventions that are not standard practice yet, such as anti-inflammatories, but maybe also lifestyle interventions such as exercise and nutrition approaches. And we are looking a little bit at some of the nutritional approaches as well. I don't have time to mention them here today, but I think this is also a really relevant field, especially for patients with immunometabolic dysregulations, because we know also from microbiome studies, for instance, that the microbiome brain axis is very relevant and really involves at various levels immunometabolic dysfunction as well. So I showed you the example of immunometabolic depression today. That does not mean that that's the only relevant biosubtype that we should be looking at. But I hopefully have also shown you today that I think we can do better job through research to help untie depression's heterogeneity. And what do we need for that? I think it's really important to think about what we need as a research infrastructure for our field to really examine these subtle etiological differences within large groups of patients. We need to extend skill. This is not something you can do in single small-scale studies. And in order to extend skill, we need to collaborate and standardize assessments of symptomatology, of the biomarkers that we're using. It's too often that everybody of us have their own instruments, and then you have nice findings, but you cannot externally validate them. We also need deeper phenotyping, and that's what we are trying to achieve at NESDA by really asking questions. If we do find something for a biomarker, do we get confirmation from genetics? What is the role of environmental pathways? These are all, I think, very relevant if you want to understand the heterogeneity to really have extensive assessments of. And then I think also we really need to move beyond single markers. I think I showed you some examples where we are now still limited by rather crude general biomarkers. And some of that starts with really the ones that are easy to assess and that are valid. But I think this is also due to the technological advancement in the field, something that we can really modernize in the next years to really get the better and more appropriate measures and integrated measures, because there may not be one single marker that will define depression's heterogeneity in much extent. I think if we do so, then we should be better able to really untie this knot of this depression heterogeneity. And I think with that, I would like to thank you, and I would like to thank lots of people working with me at the NESDA project and all the other projects I showed you. And it's really, I think it's a complex field to be working at. I think it's a challenging field, but I think it's also a really very much fulfilling field, because I think we can really do much more than has been done. And I think we really should take the step to really bring that to clinical implementation. So thank you very much. And with that, I think it's time for questions. I have no watch, so I don't know how late it is, but...
Hi, Brenda. Thank you so much for this very interesting talk. You absolutely convinced me. I have the work you have presented is mainly based on data from unipolar depression, and I was wondering if you think that it could be also applied to bipolar depression.
Yeah. So does this work? Yeah, I think it works. Thank you very much for your question. I think it's a really relevant question. So when we started our project, we did not include bipolar patients. However, down the road, if you start with unipolar patients, you actually end up also with some bipolar patients because some people developed bipolar disorder. So we have been analyzing some of those persons. We do not have many, but about 50 to 60 people have developed bipolar depression during time. And we actually have confirmed and also described already that immunometabolic dysregulation actually predicts the development of unipolar into bipolar disorder. So I think that is really extremely relevant to know. We are also collaborating with another cohort in the Netherlands that is zooming in especially on bipolar disorder. And we are actually with them now working on looking at some comparable biomarkers between unipolar and bipolar depression. But yeah, I wish we had had more funding so that we could have included a larger group of bipolar patients also. And I think that's exactly, I think, what your French cohort in the future could be doing, because I don't think there are that many studies that really have huge numbers of unipolar and bipolar patients and then really allow a direct comparison. So not an indirect comparison, because I think we have many of those in the literature, but a direct comparison using the same assessments and the same tools and then comparing unipolar and bipolar patients. I think that would be really important.
Thank you so much. And this is absolutely what we are going to try to do.
Yeah. So just before giving the floor to Bruno Wizerath, this is exactly the data we have already. So we may think of building a collaboration between the network on expert centers for bipolar patients to be able to compare with your data.
Yeah, and I would be very interested to, for instance, also see whether the immunometabolic dysregulations in bipolar patients is also driven by atypical energy-related symptoms. We have some data from schizophrenia in the Netherlands. There is a big group study, the project that was started 20 years ago as well. And they have also included inventory depressive symptomatology and some biomarkers. And we actually are completely replicating within a schizophrenia cohort now the relevance of the energy atypical symptoms.
Maybe something else we could build with our colleagues from the network on schizophrenia as well.
Yeah.
Bruno Wizerath from Bordeaux has raised his hand.
Many thanks, Mario. Many thanks, Brenda, for your large overview of your amazing research and exciting research in the field of depression. How do you explain, just a question, how do you explain how typical depression is characterized by high cortisol levels but less metabolic dysregulation, regarding the potent pro-metabolic effect of hormone glucocorticoid hormones known to increase glucogenesis or decrease insulin sensitivity?
Yeah, so I think that's a really good question. So we collected in our project, we collected saliva cortisol assessments. We have cortisol awakening response. We have evening levels. We then can look at the diurnal slope. And we even did a DST test in some patients. And then we have the immunometabolic markers. We expected to see a positive association, like you mentioned, because HPA axis function, we know hyperactivity of the HPA axis, for instance, is generating lots of immunometabolic responses. However, none of those correlations in our project were at all significant. So, and I know that, you know, from animal models, from some other literature, there should be a strong connection, but we have never been able to confirm it in any of the biomarkers we have measured. And we do have quite, I think, large sample size for this. I think part of this may have to do with the fact that The HPA axis is really a difficult beast to measure. So even with saliva cortisol measures, it's not very easy to get reliable measures. You know, the timing issue is very important. We now have, at another wave, we have looked at hair cortisol measures, which may in a certain way be even a more relevant measure because it's more the chronic HPA axis dysregulation that we are finding. And we actually have never looked yet at the hair cortisol levels in these two subgroups. We have confirmed that hair cortisol is very relevant for metabolic dysfunction. So there we did confirm that people with high hair cortisol levels, for instance, were the ones with obesity and metabolic syndrome abnormalities. So we should probably repeat that analysis also for the subgroups. But yeah, this is really quite striking, and we did find quite significantly the difference between the HPA axis, where cortisol reactivity was just much more prominent in the typical depression, and it were the immunometabolic features that were more prevalent in people with more atypical symptoms.
Thanks, Brenda.
And this was actually confirmed by there is a Tulsa 1000 study in the US, and they actually have confirmed exactly the same findings as we have. So they also put HPA axis disactivation more with the typical depression and immunometabolic features with the atypical depression. So it's not only us finding this.
Thanks, Brenda.
Very much, except if there is a burning question, I think we have to thank Brenda. I'm sure you're all as convinced as I am that the field, thanks to Brenda, publication and production, is ready for implementation. So it's really a very important example and very important for our patients. Remember that they lose a lot of years of life because of this immunometabolic abnormality. So it's really important to keep this in mind. So with these words, please join me to thank and congratulate Brenda